Good afternoon and welcome. My name is Carrie Conley. I am the Director of Programs and Services for the Scleroderma Foundation's National Office. Thank you for joining the Scleroderma Foundation's Virtual University Patient Education Fall Series. We are excited to host today's event, Pain, Its Causes, and Its Treatments. Before we get started, I want everyone to have a successful experience, so I have some quick notes to share on today's event. If you're properly logged into the webinar, you should be seeing the first slide on the screen and hearing my voice. If you have dialed into the event by phone, please turn the computer microphone down to avoid any sound feedback. If you are using a handheld device, you may be required to swipe right or left to view the full screen demonstration. Today's webinar is being recorded and will be made available after its broadcast. The Scleroderma Foundation in no way endorses any drugs, treatments, clinical trials, studies referenced in today's webinar. Information is provided to keep the listeners informed. Because the manifestations and severity of scleroderma vary among individuals, personalized medical management is essential. Therefore, it is strongly recommended that all drugs and treatments be discussed with the individual's physician for proper evaluation and treatment. This webinar is for educational purposes only. We encourage attendees to use the question and chat feature opportunity on the sidebar. Team members from the national staff will be hosting a question and answer segment at the end of the presentation if time permits. So let's get started. I am happy to introduce today's speaker, Dr. Daniel Furst. Dr. Furst is a professor of medicine at the University of California, Los Angeles. He is also adjunct professor at the University of Washington in Seattle, as well as research professor at the University of Florence in Florence, Italy. He also has part-time practices at the Arthritis Associates of Southern California and the Seattle Rheumatology Associates in Seattle, Washington. Dr. Furst has been a longtime member of our very own Scleroderma Foundation's National Medical and Scientific Advisory Board. Additionally, he is a member of the Scientific Advisory Board for the Arthritis Foundation, as well as serving on the Board of Directors for the Foundation of the Collaboration of Research Rheumatologists of North America. Dr. Furst is on the editorial review board of numerous clinical pharmacology and rheumatic disease journals. He has written over 800 original articles, reviews, and chapters, and has written and edited 14 books on rheumatic diseases. Welcome and thank you for joining us today, Dr. Furst.
So good day, everyone. My mother really would have enjoyed that introduction. So she thanks you if she could. What I want to do today is talk to you about pain. Next slide. Next slide.
Yep, sorry.
Next slide.
Yeah, sorry, Dr. Furst, it's just giving me a problem right now. There we go.
There we go. I have a number of disclosures. I work with a lot of companies to be able to do my research. Next slide. I want to talk to you about pain because it's really a very important issue. Next slide. One of the things I want to do first is I want to get you to understand pain, and then we'll talk about its treatment. You can see here that pain is a very important issue for patients. The skin, the hands, and pain are the most severe problems in patients with scleroderma. Next slide. And you know, if someone has pain, it has downstream effects. You can see here in about 1,000 patients that there are a number of things that result in fatigue, and pain is one of those. So if you have pain, you may have more fatigue. Next slide. Next slide. Seem to be having trouble.
Yeah,
Next
sorry
slide.
about that. Sorry.
Could you go back one, please?
Sorry.
All right, let's hope this gets a little smoother. So there are different causes of pain. Next slide. These are they, and this Venn diagram shows you sort of how much of pain is due to what. So you can see on the left upper corner that says autoimmune and inflammatory disorders. And things like lupus and sclerotic. Please go back one. Wow. You can see that things like lupus and scleroderma are associated with this kind of pain. It's kind of a nociceptive, it's called nociceptive because that's pain from the periphery. And that occurs in a lot of patients, you can see there. There's also anatomically defined pain. And that is both the kind that you feel coming from the periphery and the kind that's related to joint and muscle and mechanical problems. And then a large part of pain is what's called affective pain or central pain. And you can see that 15 to 20% of the population have these kind of symptoms. And these things all coexist. Next slide. So most pain has both sensory and emotion-related pain or affective pain. And that Venn diagram showed you what it did. While I'm going to try and separate these things, they never occur just in one area. It's always a mix. Next slide. So to understand this a little better, I want to talk about the genetic components of pain. Next slide. There's clearly a strong familial predisposition. In patients with chronic pain, the odds ratio of if one person has it, of another person having it, is 800% higher than normal, an odds ratio of greater than 8. And there are genes that are associated with them. You can see them here. The one I want to mention most is serotonin, because we'll get back to that later. But genes are associated with it. It's very clear that it's more common if a person's had a family member who's had a lot of pain before. Next slide. And it really makes a difference. There's something called a mu receptor. That's like for morphine. And if a patient has 2 doses of it, then those people will require more morphine and have more drowsiness than others. In other words, these are people who are quote unquote resistant. On the other hand, there's another kind of receptor which is associated with a particular drug called pentazocine. And if people have that gene and it's not functioning, then they'll have more effect. And it turns out that if people have this and they're a woman, they have a greater effect than men. And this is wild. 75% of pale redheads, if they have this, get better analgesia. The point here is that the genes really do affect how people respond. Next slide. So let's break this down. First, let's talk about anatomically defined joint, muscle, that kind of pain. Next slide. What happens here is if there's inflammation in the joints, the tendons, the muscles, the nerves, that can cause tissue damage, and tissue damage results in pain. We can all understand that. Next slide. If you think about a patient with scleroderma, and let's look at her hand, you can see in this person's hand that her hands are swollen. And it's very hard to tell if there's something going on in the joints. They're kind of buried in the swelling. You can't tell if they're red. You can't tell if they're swollen. It's very hard to tell what's going on. Next slide. And this was looked at by us a while back. And it turned out that among 7,000 patients, aching in the joints occurred in 50% of the patients, but synovitis, that is swelling of the joints, was found in 16% and swelling of the tendons in 25%. In other words, not all aching can be measured in terms of actual inflammation. Next slide. And that kind of pain can be anywhere. It can be anything. So it can be stiffness, it can be onset, it can creep up on you, it can be a few joints or many joints, and it can be anywhere, in the fingers, in the wrists, ankles, anywhere. Next slide. And really, how much you find is dependent on how you look. This looks at ultrasound, which is more sensitive than clinical. On the top left, what you see is those orange and red pictures show increased blood flow where there's increased inflammation. It's called a power Doppler. In the bottom are grayscale or regular Dopplers, and you can see on the left where there's swelling, those gray areas, and on the right at the bottom there where that kind of line is, you can see where there's breakdown of the bone or erosions. So if you look at this, you can see if a group of patients is examined by ultrasound, about 50%, not the 16%, have inflammation of the joints, a quarter have inflammation of the tendons, and that's much more frequent than clinical, where it would be 30 and 20%. Next slide. So you can see that there's a lot going on in the joints. Let's look at the musculoskeletal system. Next slide. So when we think about the joints and the musculoskeletal system, we talk about treating it. And these are the drugs, and you're all familiar with them, that are used to treat scleroderma. But they're not pain medicines. They treat the underlying damage and then secondarily treat the pain. They don't treat the pain itself. Next slide. And when we think about pain in the muscles, you have to think about something called inflammatory myositis, or inflammation in the muscles. On the top there, you see what a normal muscle biopsy would look like. And then in the bottom, when there's inflammation, and all those black dots are inflammatory cells, and you can see that the muscles have been damaged. Next slide. What's found is there's increased enzymes called CPK in the blood. There's inflammation, such as you see here on the biopsy. Next. There's weakness. The EMG, which is a way of looking at the muscle nerve interaction, are particular, and this kind of thing responds to corticosteroids. So here we're treating pain and weakness with a corticosteroid, not an actual pain medication. Next slide. So if we want to get into that, that's a whole new lecture, but I think it's worth pointing out that when there's that kind of inflammation, it can be treated. It's not part of this lecture, but it can be treated. Next slide. And here is a person with a lot of calcinosis. Many of you may have some of that. That's calcium under the skin. Next slide. And if you look at an X-ray, you can see the calcium. That's that white fluffy stuff around the bones and joints. Next slide. And if there's inflammation in the tendon, that's associated with what are called tendon friction rubs. Patients who have that, particularly in the morning, it literally creaks and goes, and it can happen in the shoulders, the elbows, the wrists, the fingers, the knees, the ankles, anywhere. And it's a sign of inflammation in those tendons. Next slide. How do we treat that? One, we treat it with steroid ultrasound. So you put a steroid on it, you use ultrasound to drive the steroid onto the tendons and help treat those tendon friction rubs, which can be painful. Remember, we're not using a pain medicine, we're treating the inflammation. Next slide. You can also, nope, back one. You can also, nope, back one. You can also treat the inflammation itself with not just the steroids, but with non-steroidals, with the things we talked about before, methotrexate and biologics. We're treating inflammation, not treating pain. And the treatment of the inflammation improves the pain. Next slide. You can use NSAIDs. This is a study in kids with arthritis. It was 1,000 patients. And what they found basically, there was NSAIDs like Mobic, diclofenac, Celebrex. You get about a 30% improvement in these kids and in adults as well. And it doesn't only help the pain, but it helps them globally. So in these kids treated with Advil or aspirin, they felt generally better, about 85, 90%. So treating these pain from inflammation with NSAIDs can be effective. Next slide. What about using things like opioids? Here was a study over a year in 200 patients, and the patients were either given things like Percocet or Norco or even stronger medications, or they were given Tylenol or various NSAIDs like Celebrex. And if you look on the right, you can see that they were about equally effective by the end of a year. So that the opioids and the non-opioids were about equally effective on the mean. Obviously, for any individual, it may be different. But there was one other thing that happened. And if you can see on the left lower corner where it says adverse events, there were twice as many adverse events. You see the number 1.8 under opioids as there were with the NSAID, with the non-opioids, which was 0.9. So they work about equally, but there will be more side effects with the opioids. Next slide. Next slide. I want to take a slight sidelight to cannabis. There are many states now where this is legal, and I think it's worth talking about. So cannabis is found in all sorts of plants, and there are different types, different species, and you can see that. Indica, sativa, ruderalis, and there's a spray that's been made for that. The cannabinoids are part of the cannabis, and there are multiple of them. There are those produced by the body, that's endocannabinoids, and they bind to cannabis binding receptor 1 or 2. And then there are the cannabinoids from plants, and there are 80 different cannabinoids in cannabis. Of course, there are also the synthetics. Next slide. The THC, the tetrahydrocannabinoids, affect the CB1 receptor. They're associated with decreased depression, anxiety. They affect memory and they affect pain. CBD affects the receptor number 2, and that affects more inflammation as well as neuroinflammation. So it affects different things. Next slide. And here are a bunch of studies looking at what kind, how cannabis affects different kinds of pain. There were 4 studies looking at cancer pain, and they were all positive. On the other side, there were 2 studies looking at chronic pain, and they were positive. But if you look at neuropathic pain, we'll talk more about that, or acute pain, you can see it was about half and half. So I think what you can say from this is that cannabis can help cancer or chronic pain, not so much other types. Next slide. And here's a study which looked at a synthetic that affects CB2, like the CBD, in knee pain. And the red line shows that a certain dose of this synthetic improved pain more than the placebo, where the line did not go down as much. Next slide. So what about the cannabinoids? First of all, if you're going to use them, there is a problem. If you go to the same store and get supposedly the same stuff, it's actually different every time you go in. So it's hard to tell how well it's going to work from time to time. If you use something like CBD oils or something where you can get a number, you start at a low dose here, 5 to 10 milligrams, and then gradually go up until you find a dose that works. Remembering from time to time, it's not necessarily going to be the same. Sometimes the CBD alone doesn't work, and then you can add a low amount of THC. So they're in the stores, there are those which say pure CBD, it's not completely pure, or CBD plus 5% THC or 10%. So if the CBD alone doesn't work, adding THC may help, thinking about the mechanism on CB1 and CB2 receptors. It's better to use oral dosing than inhalers or smoking. Next slide. So let's go back and talk about, we've just finished talking about the anatomically defined pain. Now let's talk about autoimmune or neuropathic or nociceptive. That's the type that's associated with inflammation, such as in scleroderma. Next slide. One of the things that we found is that pain in scleroderma is split upable. This looked at 120 patients, and it looked at various measures. And what you see is that pain occurred in 70%, but half of that, 36%, was neuropathic pain. Neuropathic pain tends to affect the face and the legs and the gluteus, just like low back pain. The thing to remember here is that neuropathic pain occurs in about accounts for about 1/2 of all the pain. Next slide. Now that's not completely true. This looked at a smaller group of patients, and what they found was that the neuropathic pain was of different types. And in this case, it was only 1/4 of them. But the kind of pain was like feeling great discomfort or burning in the stocking and glove distribution. And there was decreased ability to tell vibration and feel how you're walking and things of that sort. And those things affected quality of life. You can see on the right that if there was neuropathic pain, quality of life decreased by 50%. And depression increased by about 50%. So neuropathic pain really affects quality of life. Next slide. How can you tell if it's neuropathic pain? First of all, it tends to be burning or numbing. And that's the most important differential. And we don't treat that with just plain old pain medicines. You've got to treat it with things that affect the nerves, both peripherally and centrally, like neurontin or pregabalin or Keppra. Acupuncture is sometimes used. Transcutaneous nerve stimulation can be used. So treating this kind of pain is quite different than treating the other kind of pain. Next slide. Now let's talk about affective or central pain. Remember, that's the one that's most common. Next slide. So if you look at a bunch of patients with scleroderma or lupus, 20 to 25% of them have pain that is not the anatomic or inflammatory cause. And it doesn't correlate with disease activity or damage. And if you're likely to have affective pain, it's a predictor of of decreased function. So it's common, it doesn't correlate with disease activity, and it affects function. Next slide. So how common is it? This chronic, widespread kind of affective pain in this group of about 50 didn't correlate with the skin, but it was found in about a quarter of the patients. So chronic, widespread pain in this study, a quarter of the patients. Pretty common, isn't it? Just like in the general population, which is about a quarter, 10 to 15%. Next slide. So how does this associate with chronic pain? Well, if you had that genetic predisposition and you're under stress and you don't have the right kind of environment, it isn't supportive, then you can get symptoms. Next slide. And if you get symptoms, next slide, that ends up with getting in the way psychologically. You get decreased activity, you get more isolated, you don't sleep well, you feel worse, you can't function very well. Next slide. Which leads to more symptoms, and round you go. So psychological factors can really affect chronic pain. Next slide. So let's talk about what brings it on. First of all, what are the triggers of central or emotional pain? Next slide. Well, infections. Think coronavirus. Think EBV. Physical trauma, automobile accidents, falling downstairs can trigger it. Psychological stress, loss of a family member, breaking up of a marriage. Hormonal effects, thyroid problems, menopause can bring it on. There are drugs, and some people say vaccines, but the actuality of vaccines is that it's probably stress related because people are worried about it. It's interesting that catastrophic events can bring it on. So war, but not, for example, I live in California, so we think of earthquakes. Other people think of other things, but those don't bring it on. It's only these wars and unnatural kind of disasters. Next slide. One of the things that's associated with scleroderma is appearance. When you're worried about the way you look, you can get depressed and anxious, and you can do something called catastrophizing, and we'll talk about that a little bit later. And that brings on pain and fatigue. So the fact that people have scleroderma can bring on increasing pain and fatigue through secondary mechanisms. Next slide. So next slide. Next slide. And when there is affective and emotional problems, it complicates pain. Next slide. And what can be done about it is thinking about cognitive factors. So for example, dealing with feeling like you can't control it. You lose control, you lose locus of control, and catastrophizing, which we'll talk about. Next slide. And men and women deal with this kind of pain quite differently. Women experience more pain, but it doesn't carry over. So they feel pain one day and they don't feel it so much the next day. It doesn't bother them as much. And what What women do to deal with the pain is use things like spousal support, getting encouragement, sharing concerns. Next slide. In contrast, men try to deal with pain by using problem-focused strategies like redefinition, we'll talk about that, or relaxation. They tend to have more carryover. So if they have it one day, it tends to bother them more the next day, less than women. Next slide. So let's talk about that a bit. When we're talking about emotional focused pain, to deal with it, you redefine it. You look at it differently so it's more bearable. For example, you can say something like, you know what? I have it, but by God, I can still do what I want to do. So it's not killing me, it's bothering me, but it's not so bad. That's redefinition. You can also talk about it. Talk about it to someone in terms of how much this is bothering you, because that decreases anxiety and tension. You can get spiritual comfort. Prayer, spiritual support can help. And you can get emotional support from your family, friends, or professionals. When you talk about problem-focused pain reduction, it's doing something. For example, taking meds, taking transcutaneous nerve stimulation. You can try and relax, massage, hot baths. You can try and distract. Do something else, play, read, coach. Next slide. Now, I talked about it as if emotional was for women and problem solving is for men. First of all, that's not absolute. No rules are absolute. Most people have a little of both. They may have more of one than the other, but it's not absolute, and it shouldn't be thought about that way either. Next slide. Now, I want to talk a bit about catastrophizing. It's kind of a loaded word, but let's talk about it. Next slide. What is it? Well, it's predicting the worst. It's assuming that if something bad happens or could happen, it will. And if it happens, it'll be catastrophic. And if it happens, it'll change your life and last forever. So for example, you get a panic attack when you go to Walmart and you say, that would be the end of the world, not just something that's unpleasant, but if it happens, your whole world will never be the same. That's catastrophizing. Or that you'll be unbearably lonely 24/7 for the rest of your life. It'll never change. It'll never go up and down. That's catastrophizing. Next slide. Everyone does it. Usually it's short term. For example, if you have back pain, it goes away. You may feel like, oh my God, it's going to be there forever. But then you realize, you know what? A month ago, I didn't have it. Or dental procedures. Okay. Most people really hate going to the dentist because they're afraid it's going to hurt. But for most of us, we realize it goes away. For athletes, it's typical. They sprain something. They feel, oh God, I'll never be able to do any athletics again. And then it goes away. So all of us do it. It just tends to be short term. Next slide. So what can you do to prevent this? First of all, you can catch yourself. You see yourself what's called ruminating. You keep going back again and again, and you notice that you're doing it and say, you know what, this doesn't make any sense. You can try to realize when you're magnifying it. Back pain is 5 out of 10, but all of a sudden you think of it as 10 out of 10. But you know, if you realize that 10 out of 10, but you're still able to get around the house and be able to do things, maybe it isn't actually 10 out of 10. It's actually 5. Or you feel helpless. For example, it hurts, so you feel like you're never going to be able to go shopping again. When you could use a cane, wait for it to get better, can deal with it by trying not to feel helpless. And then you can think about positive or neutral outcomes. You may not be able to wash the dishes today, but if you do physical therapy and so on, you may be able to wash it another day so that you can do something about it. And then, very importantly, you have to separate the unpleasant from the catastrophic. A student may fail a test. That may not be good, but it doesn't mean that they'll never be able to work or be a success later on. So it's unpleasant, but not catastrophic. So doing things to realize what's catastrophic, what's catastrophizing versus what's normal can help you get past that kind of a problem. Next slide. So fibromyalgia is a prototype for central pain. And I'm going to use these terms interchangeably. There may be small differences, but basically we're going to talk about chronic pain syndrome, so central pain. Next slide. In central pain or fibromyalgia, it's been noticed that the brain waves are different. If someone has fibromyalgia, like in the upper part, lower part, where all the lines are together, that's what fibromyalgia does. You get a couple of points like you do in the others, and then they all begin to interact. So it kind of spreads the pain and makes it worse and worse mentally. And that's actually been found in EEGs. And if you increase what's called coherence, increase the interchange, it makes it less likely that you'll be able to improve pain. You can see here, if you don't have a lot of that interaction, your pain improves by 40%. If you do have a lot, it improves by 20%. So there's anatomical correlates to central pain. Next slide. What's going on is what's called volume control. Patients with central pain can feel about the same as anyone else. That is, if a person with central pain is pricked with a pin, it hurts a tremendous amount. But they can feel it no differently and the same as someone who doesn't have it. They both feel it about the same, but the amount of pain differs. Next slide. What you see is this. If you think about pain intensity of a level of 6, okay, and you have someone who doesn't have central pain, you'll see that it takes a level of 7 stimulus, much more stimulus, to get to that level of 6. If you have central pain, you get that same level with much less stimulus. So here's an example. Some people, or most people who don't have central pain, if someone touches your skin, it feels like someone touching your skin. But that same amount of touch with someone with central pain can hurt. Volume control has changed. Next slide. Next slide. First of all, you can recognize central pain because it isn't associated with injury or spasm. Next. And it's not where you expect it. If you injure a shoulder, it isn't that it just stays in the shoulder, it's all over the body. Next slide. And it's very sensitive. I talked to you about light touch causing pain when normally it wouldn't. Next slide. And it doesn't respond to the usual pain medications, like pain medications or TNS or injections. Next slide. And it's associated with lots of other things. It's just not just pain, but it's fatigue, it's foggy thinking, it's generalized distress. Next slide. Everyone has some of this, and having a few or intermittent symptoms doesn't mean you have uncontrolled central pain. But if you have all of these and it goes on all the time, it really has to be considered potentially central pain and should be treated differently. Next slide. So let's talk about treatment. Next slide. There are a number of treatments we can use, and we'll talk about some of these. Next slide. There are a number of non-pharmacological treatments. The Veterans Administration has had a large amount of work done in this area. And what they found was that chiropractic care is approvable because it works. Massage, manual therapies, acupuncture seem to work, has been approved. Various exercises, particularly aerobic, we'll talk about that. Mindfulness exercises like yoga and Tai Chi. Cognitive behavioral therapy, understanding what it means. And getting some psychological therapies are all approved for central pain syndrome because they all seem to work. So massage, exercise, yoga, psychological therapies work. Next slide. What about exercise? What kind of exercise? Well, first of all, it's aerobic. Okay, it really helps everyone, but keeping it up is a hard problem. Most people start it, but keeping it up long term is an issue. So it may help, but it just falls by the wayside. You start with low impact exercise for a short time, like isometric exercises for 5 minutes. Don't do strength training till later on. And it's really important. It's as important as the drugs. Aerobic exercises are more important than strengthening and stretching, even though the stretching feels good temporarily. Long term, aerobic exercise will help you more. Next slide. And there are medications. The kind that affect serotonin, remember that gene we talked about? Don't work quite as well as those that affect both serotonin and the other central nervous system substance called norepinephrine. They have mixed effects. The best ones are things like Effexor, amitriptyline, Cymbalta, Savella. Those are the ones circled. The ones to the left, like Paxil, paroxetine, these other ones are not quite as effective. Next slide. What about all these other things? Acupuncture, etc. We talked about that. What about biofeedback? Well, it actually works in about 60 to 70% of patients. So it's worth trying. Next slide. So what we've done is we've talked about the 3 different kinds of pain, their overlap, their causes, and their treatments. Next slide. I want to summarize this a little bit for you. And this is the medication portion of it. The peripheral or nociceptive kind, that's what we call the anatomic, versus the neuropathic, which is still peripheral, but is associated with the inflammation, versus the centralized. NSAIDs, like Celebrex, etc., work best for the anatomic or peripheral. The opioids work for both that and the type associated with the diseases like scleroderma. Injections and surgery work for both of those. The tricyclics like amitriptyline work for all three types. And things like Cymbalta, that mixed group, work for all three types. Gabapentin works best for the neuropathic. So that's the peripheral neuropathic and the centralized. CBD works best peripherally, and THC works best centrally. So you can see that since most of us have pain that affects all three, you're going to have to use a mix of medications and add to that exercises and add to that psychological approaches to pain. If you do all those things, the chances of you being able to be treated successfully for your pain increase significantly. Next slide. Thank you very much for your attention. And I hope we have a little time for some discussion.
We do. Thank you, Dr. Furst. That was a fantastic presentation. Great. It looks like some of the attendees have taken the opportunity to ask Dr. Furst a few questions. We have National Team Member Angel Soto, Programs and Services Associate, here to facilitate our question and answer segment. Angel?
Hello, and thank you, Carrie, and as well as thank you to you, Dr. Furst, for that presentation. I'll get right into some of these questions.
Nice to talk to you, Angel.
Yeah, it's been a bit. So I'll get right into some of these questions. We've got a few. So first of all, we have, will treatments for inflammation help with relieving the pain caused by calcinosis?
It's a great question. The answer is calcinosis, because of the calcium, causes that inflammation around the calcium. So if we can decrease that inflammation, we will help the pain. Now, are there any studies to support that? Actually not. I'll tell you what I actually do. For one thing, there's something called sodium thiosulfate. That seems to be, there has been one study which looked at that. And if there's an open area in an ulcer with calcinosis, using thiosulfate, which is a liquid you put on the calcinosis, seems to help the inflammation and actually may even help the calcinosis. Using medications like biologics, for example, TNF inhibitors, etanercept, Enbrel, things of that sort, I've used some to really help people with bad problems. Of course, you never get something for nothing. So if you use some of these medications, you have to watch out for side effects. Sort of the simple answer is, if you treat the inflammation around the calcinosis, you're likely to improve the pain.
Perfect, thank you very much. The next question is, my doctor doesn't like to address pain and often recommends that I go to a pain management clinic. Would you recommend this also?
I think that depends on both you and the doctor. Some of us have no trouble dealing with pain of this sort. But if your doctor feels uncomfortable, the pain clinic actually does more than just injections, or at least a good one, a good pain clinic. They'll deal with all the things I just talked about. One thing you can do is find out if the pain clinic to which you're referred usually does nothing but injections and things of that sort. It's probably not the right place. You probably need to go and maybe combine. That is, go to them and also go to a cognitive behavioral therapist. That can be a social worker, a psychologist, thing of that sort. At UCLA, there's something called the East-West Clinic. They tend to use a combination, and that would be a very good place to go. So if you can find something equivalent to an east-west complementary and usual medicine pain clinic. That's the best thing to do. Again, bottom line, if your doctor isn't comfortable with it, you got to find someone in addition who is comfortable treating your pain.
Thank you. When do I know if I should switch my pain medication treatments? Are there any telltale signs that I may be using the wrong medication?
That's another very good question. Generally speaking, if you use a pain medicine and it does absolutely nothing in a month, it's unlikely in and of itself to be sufficient. Frequently, getting a treatment at a given dose for 2 weeks with absolutely no response means it's not good enough. You may need an increased dose. You may need a different medication. More than likely, you'll need a combination. We talked about that. And remember that most pain is a combination of inflammatory plus minus anatomic plus minus affective. So you got to do all. So I think the answer is if a given medication at a given dose does nothing in 2 to 4 weeks, you got to do something else to help with the pain.
That's wonderful advice. In here we have, if I've had scleroderma for a very long time and I've become almost accustomed and normalized the pain that I'm experiencing, what sort of pain should I be concerned about, and should I still be seeking treatment at this point?
You know, remember one of the ways that I recommended dealing with pain is redefining it. I think whoever asked that question has done some very, very good redefining of pain. I think if the pain is something that's in the back of your mind and allows you to function well, then it's not critical, but it's always nice to have less pain. So I don't say to someone, live with it unless they're very comfortable living with it. So for example, I always ask about how much pain a person has had in the last week or today. And if the pain is at the level of 2 or 3, and people are reasonably comfortable, well, you know, you never get something for nothing. So adding medication might cause more problem than it's worth. But it is worth trying some medications to see if you can bring that pain from 3 to 1. So my advice usually is if the pain is bugging you, then we need to try and do something about it.
Thank you. This question is, should my rheumatologist be my main point of contact when addressing pain medications and treatments?
A very good question. Not all rheumatologists are the same. I think that rheumatologists as a general group realize that pain is a major portion of what they're trying to treat. So in general, your rheumatologist should be trying to deal with the pain. I think that one of the reasons I went into rheumatology is it's not just a one system problem. It's the whole person and the whole body. And if your rheumatologist thinks of you as a person rather than you as a joint, then I think the fact is that that might be a good person to go to deal with pain. And you might have to explain to them a little bit about what you learned today. That you might need their help in treating the different aspects of pain. The nociceptive, the neuropathic, and the affective. And if they're thinking of you as a person, they should be very comfortable helping you do that sort of thing.
Thank you. Um, with all the fear around opioids, when is the use of chronic opioids appropriate?
So I'm going to betray one of my pet peeves. I think that this whole opioid thing applies very well to many people, but it does not apply well to patients with chronic pain. Most patients are not addictive personalities. If a person is not addictive, they're not going to get hooked. In fact, they're going to come off it before they should. To me, chronic opioids make a lot of sense for people who don't find themselves using more and more. If you find yourself going out to rob a bank so that you can get the opioid, well, then probably these are not good for you, right? On the other hand, many of my patients have been on these for a very long time. And what I do is when they're doing well, we sometimes say, okay, do you think you can cut back on a little and see if we can cut back? Some people are quite able to do that. I also periodically just check to make sure that they've not gotten drawn into other opioids. So we do a toxic screen once a year or so. In fact, that's required in California. But generally speaking, I think that patients with chronic pain who use chronic opioids and who have a stable need are appropriate for opioid use.
Thank you. The next question is, I have pain in various parts of my body on different days. So one day it may be my wrist, another day my shoulder, so on and so forth. Is it normal to have pain in varying areas of the body, or is this a symptom of something else?
So the fact of the matter is that is quite common and actually is normal. It says that the inflammation may be different in different parts, and it says that there may be different reasons for the different pains. Some of that is the anatomic, some of it's the inflammatory, and that moves around, and some of it, if it's kind of widespread, may be the affective. Bottom line, moving around is common, it's normal, and it has to be dealt with sort of in the context of the whole person.
Thank you, Dr. Furst. So we're getting close to the top of the hour. We have time for just one more question. And this question is, early on in your presentation, you had mentioned ultrasound as a means of treatment for tendon friction pain. Could you elaborate on this just a little more?
Yeah, I think there may be a bit of a misunderstanding. The ultrasound is used to diagnose it. When there are tendon friction rubs, the use of ultrasound can be done. This is how that's done. You take, usually it's a physical therapist or an occupational therapist, takes a cream, a steroid cream, rubs it in the area where the tendon friction rub is, then uses ultrasound at a relatively low frequency to drive it through the skin to the tendon. Normally that's done, for example, 3 or 4 times in the first week, and then maybe once or twice a week. And after a while, it may not need to be repeated, but initially doing it daily may be necessary to drive that through the skin. Now look, if that tendon is very deep, let's say the tendon is in the upper thigh, where the muscles are very, very thick, the ultrasound won't drive it through the muscle. It has to be superficial to work. Around the knee is superficial, the elbow, the fingers, the ankle. So most of the areas where you feel the tendon friction rubs are superficial enough so that ultrasound can work. Now look, are there data that prove that? Actually not. It would be wonderful to do the appropriate study, but it does seem to work. And there are a number of reasons for it. It's a totally different lecture.
Excellent. Thank you, Angel, for participating in the question and answer feature. We had some great questions, great dialogue. Dr. Furst, any parting comments as we wrap up today's session?
Yeah, actually, first of all, thank you all for listening. I do appreciate that. Second of all, remember that pain is a multifaceted item and needs to be treated with multiple modalities. And if you do that, you're very likely to be able to get better control of your pain. So hang in there, folks. Thank you.
Wonderful. In closing, I would like to thank Dr. Daniel Furst for being such a strong champion of our mission and for sharing your time and expertise with us today. And also thank you for dealing with some of the few technical hiccups that we had at the beginning of the broadcast. Thank you to our attendees that logged in or dialed into today's event. And thank you to our Diamond National sponsors, Actelion Pharmaceuticals and Boehringer Ingelheim. We will be hosting these virtual university webinars weekly. Next Wednesday, September 9th, we will have our first in the fall series Spanish-led webinar. Dr. Fabian Mendoza, Associate Director of the Scleroderma Center in Thomas University, will be speaking on GI-related issues in scleroderma. As always, stay connected with us through our website, scleroderma.org, and social media outlets to stay informed on the upcoming virtual university events. And thank you as well to all of our great chapter events that are happening across the country now. This will conclude today's webinar. Be well and have a nice day. Thank you.